All right. Why don't we get started? Welcome everyone. Today we're going to be hearing from two presenters on the second part of our two-part web series on some of the G6PD testing activities in Bangladesh. And so this is going to focus on user perspectives, moderated by Sandra Incardona from FIND, and our speakers will be Nora, Engel, and Cristian, Ghergu. Just as a quick reminder for our participants and for any new participants, the G6PD Operations Research Community of Practice is a collaboration of researchers, organizations, malaria control programs, and clinicians that are working to advance the introduction of G6PD diagnostics, specifically in support of radical cure treatment for vivax malaria. So in this group, we're trying to really harness best practices and lessons learned, benefit from the experience that others have, and really support information sharing. And so I think following from last week's presentation, there have been a number of resources and data collection tools that came out of this work that have been shared on the website, and we do maintain a central repository of all these resources, so I encourage you to take a look at them. And I think with that, I will hand it over to our moderator to get started.
Okay, thank you, Emily. I hope you can all hear me well. This is Sandra Incardona. I'm part of the malaria and fever program at FIND. And so I will be moderating the session of today. So I will especially introduce our speakers, so Nora, Engel, and Cristian, Ghergu, both at Maastricht University. So Nora is an assistant professor of global health. She's a social scientist and particularly interested in how new technologies and interventions for global health challenges are being developed, implemented, and evaluated. For that, she uses science and technology studies, and she has conducted extensive qualitative fieldwork already in India and South Africa, among others on TB control. And so today she will speak about this work that has been done in Bangladesh on G6PD testing. So she will speak the first part of the presentation, and then Cristian will take over. He is a researcher and teacher at Maastricht University. His primary research explores the constitution of the public through participatory and ethnographic methodologies in health projects. And he works especially with marginalized communities in non-notified urban slums in India. So he will be showing the second part of this presentation today. So yeah, we are curious to hear more about this. So I'll hand over to Nora now.
Thank you so much, Sandra, for the kind introduction, and thank you for giving us the opportunity to share our results with you. Cristian, can you go on to a full screen for the slides?
Cristian, you may need to enable editing first before going to presenter mode.
Yeah, thank you. That's better.
Okay.
So we'll be presenting about a qualitative study on user perspectives on a quantitative G6PD test in Bangladesh. Next slide, please. So why is it interesting or important to study user perspectives? We know from literature in implementation science or operational research, but also especially literature from medical anthropology or medical sociology, that diagnostics or tools in general aren't necessarily enough for change. So just having the diagnostic there doesn't necessarily mean it is utilized and effective in the way that it was hoped for. So especially with diagnostics, we know that some of the existing diagnostics for malaria or other infectious diseases, especially at point of care, are not necessarily utilized as was envisioned, or they're not being used to make treatment decisions, etc. And this has to do with the fact that diagnostics, just as any other technology, harbor meanings and values for those that are supposed to use them. So they are playing a certain role in their day-to-day practice and routine. So that is why it is important to understand preferences, values, and factors that lead to acceptability of these diagnostics in routine care situations, but also questions around practical feasibility. Is there appropriate resource allocation? Is this tool workable in the current circumstances? What does it do to the routine workflows, to what is expected from patients and healthcare workers to do for this diagnostic to work? So these are some of the important notions or concepts that social science approaches are really good at researching in depth. So you can gain a really in-depth understanding of what the problem is that the diagnostic is supposed to address and solve. How is it implemented, and how does it fit into the current health system? What other factors are important to understand? What could be potential pitfalls when we implement or scale this diagnostic up further? So I would argue that adding social sciences approaches to studying user perspectives and experiences is important for all stages of design, development, implementation, and also maintenance of diagnostics. And then with users, I would argue for a rather broad understanding of users being those who interact with the diagnostic in their way while it is made to work. So those are, of course, the healthcare workers or lab technicians who actually perform the diagnostic, but also the patient who has to interact with the diagnostic in the sense that he or she has to bring a sample, a return for results, and then be willing to act on the results. But also program decision makers, suppliers, other stakeholders that have an impact on how the diagnostic is used in the end. And you'll see that in this particular study, we only talk to a fraction of those users. But ideally, you have a very comprehensive kind of analysis of different user perspectives. Next slide, please. This is a background slide on the situation in Bangladesh. The key points to take away here are that the National Malaria Program is really committed to an elimination goal. And as part of that, it is also considering all sorts of new approaches and has an active research program also into G6PD testing, or it is supporting that. It has achieved a tremendous reduction in cases since 2007, so that at the moment transmission is now restricted to those areas that are much harder to reach, so border regions, remote and forested regions. Those are important points to understand for our results as well. Vivax is persistent and it is also treated at community level, but G6PD testing is not routinely available. Next slide, please. So the objectives of this study were really to investigate the user perspectives on the biosensor for use as a test to decide on Vivax treatment. We also wanted to understand the experiences and challenges with routine malaria care and testing, and then to talk with participants about how that informs their ideas and considerations around feasibility with regard to the biosensor, but also their ideas of technology design and what they could foresee, what would be challenges or things that would work well in implementation. And by talking about these sort of factors, and notions, we would also hope to get an understanding of the implications for health equity. Next slide, please. So this is the workshop, which was the context of this study and in which the study also happened. And Shafil talked about this last week in detail. So here I just want to mention this was a training workshop for laboratory technicians on the biosensor. And they had opportunity to gain practical experiences, as well as they had theoretical sessions on G6PD testing and the biosensor, and then integrated into the workshop program, these focus group discussions took place. So there was really space and time made within the training workshop for this particular study, which is, I think, very successful, and also an important thing to consider if you want to replicate this. Next slide, please. So in that workshop, as I mentioned, medical technologies were trained on using the biosensor, as well as 6 laboratory technicians from the reference laboratory. And then after the training sessions, they were distributed across focus group discussions. And these medical technologists are, you know, what we would call lab technicians, I guess, in an international parlor. And they do all sorts of basic laboratory tasks, and they also have a diploma. And they might be those who would perform the biosensor if it would be deployed in Bangladesh. But that is not yet clear, but they might be. And so in the focus group discussions, we discussed various topics with them. And then for those who were interested and available, we followed up with them in one-on-one interviews in the weeks after the workshop. So that allowed to probe deeper into certain topics, and also to talk to them about their experiences and their reflections around the biosensor, with a little bit of time having passed since the workshop, and them being back in their routine practices. So those one-on-one interviews we did with 14 of those lab technicians that had participated in the workshop. And then we also added a few one-on-one interviews with program officers and other decision-making stakeholders, as well as consultants, and a few nurses and doctors. I have to say though, and you see that this is just one particular type of user, right? There's the focus is on the lab technicians here in this study, and they are working at sub-district and district level hospital. Now, as I was told, most of the routine malaria diagnosis and also treatment is actually initiated at the community level and by NGO workers. So that has to be kept in mind when we're talking about the results. Next slide, please. Now, what happened in the focus group discussions? Those were organized in a way that there was first a moment for participants to individually reflect and write down their reactions onto post-it notes, which were then collected and grouped into themes. So we posed 3 major questions, which were, what did you like about the biosensor? What do you think are challenges in using it, and what are some of your thoughts about when this would get implemented in Bangladesh in routine care? And so there was a moment where they first could react by themselves and note down ideas, and then we collected all of these, and that generates a very nice discussion about a broad range of topics, also by participants who might not feel very comfortable to speak up at first, you know. And then you go through these topics one by one, and you discuss, you know, who raised this topic, what did you mean by it, do others agree, could you give an example, etc. So that generates a nice discussion. And then in the interviews, those allowed us to follow up and probe deeper into some of the themes we found, but also talk in detail to participants about their day-to-day roles and responsibilities, and to contextualize, in a sense, their answers on the biosensor. And with the program officers, we also talked to them about their day-to-day work and their roles in making and implementing diagnosis and treatment guidelines, and what it takes to change those, and their considerations around G6PD testing. Next slide. So Cristian, who has collected the data together with Martin from ICDDRB, will now be talking you through the results. Over to you, Cristian.
Thank you, Nora, and thank you everyone else for being here. I will go briefly to the results and then some conclusions. So when it comes to the use of the biosensor, the main things that participants appreciated were its usefulness, portability, and ease of use. They like to compare the biosensor with a glucometer test, which was a positive thing when it came to these aspects. But by the same comparison with the glucometer, there were also a few areas where its use or the use of the biosensor came with some perceived technical complications. So these were a few steps which were using the sample collector. They prefer the micropipette because they are more they think that micropipettes are more automatic in terms of the sample size, and they're more used to them. Another point was mixing the blood sample with the extraction buffer. As a participant mentioned, at the sample collection point, as well as after buffer and some sampling, several attempts might be needed to collect the right volume of blood or reaction mixture. If the process is not right, then the result will not be accurate. In that case, in my opinion, we should be using a micropipette. So they juxtapose this fact that they have to do several attempts with the context of a busy clinic where we observed during our fieldwork that they juggle a lot of other activities at the same time, such as organizing incoming patients, receive and record their details, collect samples, conduct tests, communicate with doctors or nurses or patients. So while medical technologies should have assistance to help them with some of these activities, many laboratories do not have assistance. And in some cases, medical technologies are available only a few days a week. Then they have to catch up with the testing either by the fact that more patients come during that short period of time, or nurses or other health workers in the hospital collect samples and save them for medical technologies to conduct the tests when they arrive in the labs. In district hospitals, which are larger and better staffed than Upazila complexes, we notice different setups with separate spaces and staff for blood collection, as well as multiple medical technologies. So the practice of medical technologies and the feasibility of implementing the biosensor can vary quite a lot depending on the working environment. Other concerns were voiced over aspects related to the supply chains and the shelf life of the device. They saw the shelf life as varying in the sense that although technically it might have a long and clear-cut timeline, because it might take a long time to travel along the distribution chain, by the time it actually arrives in their laboratory, it becomes a short-duration device. As a focus group discussant mentioned, it happens that the device arrives at Dhaka and remains there for a long time. It then takes time to reach the district level, at which point it becomes a short-duration device. The shelf life of the device also matters in relation to the number of patients and the number of tests that they conduct, but we will discuss this a bit later on too. One thing we wanted to look at was the aspect of introducing the biosensor and the training that would have to accompany it, especially in areas where less P-vivax patients are present. Participants recommended that refresher trainings would be provided around every 6 months or so. And they also pointed out that trainings would be most useful before monsoon periods, because during the dry season, they would use the device much less and they would fall out of their usual practice. Another interesting and important point was the need to reconceptualize the risk and severity of P-vivax in routine care. And I think this one requires a bit of a background explanation that also Nora mentioned. So we can think of the healthcare system in Bangladesh very, very simplified, as comprised of different regional levels, and the district hospitals provide secondary health services. The Upazila level health complexes are smaller and provide primary care services. And under each Upazila health complex, there are a few community clinics. Now, most malaria patients are diagnosed and treated at community level. In the past, all patients had to travel all the way to the Upazila complex or district hospital levels in order to get diagnosed and receive malaria treatment. However, around 2008, with the introduction of RDTs, which were accompanied by treatment, it made it possible to diagnose and treat patients at community level. And this reduced a lot the workload and pressures on the Upazila complexes and district hospital. It made it also easier for the patients to receive treatment and diagnosis at community level because they didn't need to spend resources and travel and time traveling, all the way to Upazila level or district hospitals. So at the moment, community health workers refer only the patients with severe malaria to Upazila or district hospitals for treatment. This means that the patient's experience of the malaria symptoms is an integral part and parcel of their being referred to and traveling to these clinics. So because medical technologies only work in Upazila centers and district hospitals and not at community level, a large proportion of patients never actually reach the medical technologies laboratories. So if G6PD testing were conducted by medical technologists at Upazila and district hospitals, then patients identified at community level would have to be referred to these places. So it would require a shift in perception of both patients and the caregivers. Caregivers would have to refer patients to Upazila and district hospitals, and patients would have to put the resources and effort of traveling to these centers in the absence of any severe symptoms, which at the moment is not the case. They would have to experience quite severe cases in order for them to be sort of sent to Upazila centers. So it would have to be reframed with a possible future health risk that comes with the primaquine treatment. So the complications of the context of elimination. The requirements to which an implementation of the G6PD testing would have to respond to are not really set in stone. So in this context of elimination, the NMEP needs to perform case-based investigations, which mean that when positive cases and malaria hotspots are detected, they need to perform a focused investigation management, which includes deploying diagnosis technologies, treatment, and vector control mechanisms. So as vectors and patients move across these geographies and seasons, the approach resembles a cat and mouse chase, where malaria hotspots emerge and case-based management follows them. So in this way, malaria is a constantly moving target. And along with it, these technologies, protocols, and staff must travel to these specific areas. Participants mentioned challenges related to geography and remoteness with how to reach areas and lack of infrastructure for traveling, weather changes which can make the number of patients fluctuate, especially during monsoon periods, or make traveling quite difficult during the floods. So patients have to travel for days by boats or by other means to reach health centers where they can get a treatment. Also, conflict areas can affect how patients, health workers, and technologies interact. A program officer described how in some areas only local health workers can provide care, not only because they are trusted, but also because they are the ones who can speak the local languages. So this needs to be kept in mind if you want to implement any technology. And that also means that often by the book or by the protocol approaches do not work perfectly, and health workers need to make, do with and improvise with the resources that they have in order to provide the best care they can. So these aspects bring about considerations for planning and introducing the G6PD testing. This can be what are the diagnostic and treatment technologies exist already and how are they distributed geographically and within the healthcare system of Bangladesh. As we saw, the introduction of RDTs at community level changes a lot the roles of health workers and the traveling of patients. And it affects what it means for the biosensor to be implemented. or any G6PD testing. So this would have to coordinate with these technologies and with the workers and the referral systems that exist. Also related to this is the question of who should or can administer this test. And this was an important topic. During a particular focus group, participants had a long debate over the best practice or the best place for implementation. Some of them some of the considerations were that community clinics are most accessible to patients, and they already get tested for malaria and receive their treatments there from community health workers. But then again, every community clinic serves a relatively small population, and especially in areas with few malaria patients, the biosensor would remain unused for long periods of times. And other concerns were related to the limited storage facilities at community level, and were also considerations around who can administer the test were part of the discussion. And so some medical technologists argued that they would be the most suitable because of their expertise, while others argued that with extra training, nurses and community workers could also do it. So of course the referral system would be very important, especially, or regardless actually, if it is implemented in UPA-ZILA centers and district hospitals. And these shifting requirements need a nuanced discussion around flexibility and standardization. You know, what resources are required, what parts of the implementing the biosensor can or would fall outside a set in stone standardized model to implementing G6PD testing. An interesting point that came up from discussions with decision makers was the balancing act related to the number of patients and its role in implementing G6PD testing in the National Malaria Elimination Plan. One reason that would inhibit the introduction of the biosensor was that there may be too many patients. For every change in the management of the management chart for malaria, such as introducing a new diagnosis technology, you need a technical committee to assemble and deliberate on the need and feasibility of the change. And a program officer said that in a previous meeting, they did discuss the possibility of introducing G6PD testing, but that at that time they were too early and that there were still too many patients, and making testing, and this made G6PD testing too expensive and too difficult to implement. One quote from that discussion was that Bangladesh is not in that position now to do G6PD testing for every patient everywhere in Bangladesh. The case number was too high, and this would mean that the cost would also be very high. And from the medical technologists or caregivers end, if they do have too many patients, then adding another step in the case management of malaria can add too much work to their already crowded routine practice. At the same time, there can be too few patients to maintain vivax and G6PD as a priority in practice, and maintain the testing infrastructure to acquire funding, justify the staffing for it, and allow the storage space and the work required to create new policies. So program officers highlighted challenges in keeping malaria visible and the priority in the face of declining patient numbers. One of them described a moment when, as NGO workers and the government successfully implemented malaria RDTs and other measures, the proportion of positive tests reduced dramatically. And this officer explains how, as a result, both providers and patients became reluctant to test for malaria. Providers assumed malaria was gone, and patients interpreted negative malaria RDTs as a result of as a failure of the NGO to diagnose and find the disease that was making them ill, and this threatened the provider's reputation. So in order to not lose patients, providers would also stop testing. This was a very interesting quote. So earlier, the health workers from the NGO tested 10 and then found 7 positive cases. So that would be 70%, but later on, gradually, it turned to 1%. So 2 things happened. One is that the worker thought that there is no more malaria, and on the other hand, the people who used to come there when they were found negative and didn't get anything, they said, "Who are you testing? You cannot. Why are you testing? You cannot identify the disease. You cannot diagnose the disease. Then why do you take the blood? I do not like this." So both from the recipient end and the provider end, yeah, they started to become reluctant to test, and probably they were not testing. And he also argued that currently P-vivax and G6PD deficiency are not given much priority since there are fewer patients with P-vivax than P-falciparum. So this leads to the final point before the conclusions, and it is the need to keep malaria visible while proving that it is eliminable. So during our talks about priority setting and the introduction of new diagnostic tests, one notion came through, and it might seem at odds with the fact that P-vivax is seen as less of a priority, but in the context of the elimination, malaria is malaria. And this means that every case is important, whether falciparum or vivax, whether symptomatic or asymptomatic. This is different than a controllable malaria, where it is difficult to direct resources and priorities towards P-vivax. It was interesting to look at the effort it took to change the status of malaria from controllable to eliminable. And the program officer described how this process and how they had to deploy staff, technologies to gather data and show that malaria is indeed eliminable. And this data and the 2030 deadline for elimination helped mobilize resources and devise plans. So the importance of gathering and making this data visible was very important when we talked about the policymakers. They emphasized that the first challenge to implement G6PD testing is that to collect information or evidence, to see what is the status of vivax, and then you go on for the status of G6PD. And this is essential to acquire donor funding, maintain testing and treatment infrastructure, and uphold political will and leadership. So for conclusions and future work, just briefly, it was seen that the testing for G6PD deficiency is of benefit for patients and necessary to reach elimination targets in 2030. And with consideration to health equity, different patients will have different needs and access to testing. And this goes back to the map that Nora pointed at in the first part of the presentation. Also, G6PD testing is well aligned with the drive to implement a more efficient radical cure, a shorter course regimen, but doing so would require a lot of coordination at all levels of the healthcare system. Regarding the feasibility of introducing the biosensor, it was seen as easy to use, portable, with the potential challenges such as the supply chains, the shelf life, and the workload of the health workers. Remoteness does complicate diagnosing malaria and radical cure, and requires flexibility and improvisation by policymakers and the health workers. And also the finding that the requirement for that balancing act of too few and too many patients to implement the biosensor, owing to the challenges of funding, workload, and testing infrastructure. The biosensor requires reconceptualizing the risk and severity of P-vivax in routine care. And we actually saw that during the training, because most of the participants at the training were not aware of the possible risks of pre-marketing treatment. So the training not only helped them perform the test, but change how lab technicians or technologists interpreted the risks of P-vivax. So for future research, it would be interesting to look at how long will that perception last. Will it change again given workload? Will it change across seasons or across regions, or perhaps where you have more or less patients? And then again, the consideration of if the biosensor is deployed at the Upazila Health Complex, would patients travel for extra tests without having those severe symptoms that they are accustomed to as a reason to invest in that travel, especially when treatment is locally available at the community health clinic. And what other stakeholders would have to be included for this regarding the changing risk perception, and how would that be implemented at community level. So in order to maintain testing and to make new technologies such as the biosensor accessible, malaria needs to be made and kept visible, and this is done through the practice of health workers, but as well as through data collection and political will. And this points to the previous point that the biosensor requires new forms of evidence to establish that relevance of the biosensor and be able to judge its value and justify its introduction. Diagnostics take on different meanings for different users. So as a tool to offer better care, as well as, during our field work, we know one of the nurses mentioned that they do provide, they do testing, sometimes even when it's not 100% necessary, because that is a way of confirming that they are providing a good care and responding to the experience of the patient in the health clinic, as well as to strengthen one's expertise and professional role in the healthcare system, as to, who is able and what does it mean for the professional role of the medical technologists to do it as compared to perhaps other health workers. As well, it can be mobilized to support funding for an NGO. And again, to keep in mind the workloads that exist in their working environments. So different values would have to be considered when devising this implementation plan, and these stakeholders would have to be involved in the devising of this plan. So implementing point-of-care diagnostic requires strong and well-funded health infrastructure and system, and engaging these providers in the policy process as well, in the designing of the planning. It requires functioning relationships, and improvisations by providers at every level need to be considered as they play a central role and structural role in fragmented health systems to cope with uncertainty, such as stockouts and the workload. Some of the study limitations that we thought would be good to point out were that it would have been nice to be able to engage with patients and other providers at different healthcare system levels, community health workers, because they play such an important role in caring for malaria patients. And these are both national and NGO workers, NGO laboratory workers, and surveillance and communication pathways, as well as questions regarding how is the G6PD biosensor implemented and used in routine practice, because now we worked a lot with perceived or future implications in case this would be implemented. In practice, it would be very interesting to actually observe and learn how it's being implemented and assist that process throughout. And of course, for policy level and practice level, to be looking at how does G6PD testing emerge or disappear as a priority and practice. How do international and national stakeholders arrive at a consensus regarding specific changes and targets in national malaria strategies and changes to malaria management charts? These are our acknowledgement. Yeah, thank you.
Okay, thank you, Cristian. Very nice presentation. So I hope everyone has been able to follow well. And so now the floor is open to questions. So if anyone has a question, please raise the hand using the tool of the Zoom system, or you can also type your question in the chat. So please. So I don't see anyone yet coming up with a question. So maybe let me start with one. So Cristian, I think, well, both you and Nora, sorry, there are some questions. Please, I'll let you go first. Gonzalo.
Sorry, thank you. Thank you for the great presentations, Nora and Cristian. I had lots of questions, but I'll just ask one first. Was there any discussion around G6PD deficiency, the value of that test result in its own right, regardless of its use for malaria? And if there was or wasn't, would that also have been informed by the constituency of your subjects that were primarily malaria program people?
Thank you for the question. Some of the decision makers and program officers did mention that this would be of some relevance outside of malaria care, but perhaps it's also because we only talked to program officers that are involved directly with malaria. They directly associated with this process of providing malaria treatment. I'm not sure if anyone else has knows more about this.
So no other comment on this one? Well,
No,
I
I also haven't seen
know
anything in the data other than that, what Cristian just mentioned. And I think it must have to do with the fact that that was also how the workshop was introduced, and as far as I know, that G6PD testing was tied to malaria.
Thank you.
Okay, thanks, Nora, Cristian. Any other question? Emily, I saw that you had raised a hand. Did you have a question, or was that just?
No, thank you. This is actually a bit of a similar question. I was really interested in your conclusion around the need to change the risk perception around G6PD deficiency and being able to use the training that you did to actually sort of start that process. And so my first question is, particularly among the medical technologists, what was their level of knowledge of G6PD deficiency? And was that relatively consistent across the medical technologists, or did you find a lot of variation? And then my second question is around sort of any sort of specific messages or materials that you thought were helpful in sort of changing that risk perception, and kind of how you got to that point in the training.
Yeah, thank you for the questions. From our respondents, medical technologies from the Upazila complexes were not particularly aware of the G6PD risks. The medical technologists at the central lab in Dhaka, they were aware, but they are not directly involved in providing care. So that seems to be reasonably consistent across the participants from Upazila health complexes. Some of the doctors were aware of this. But yeah, this was, it seemed to be news for during the workshop for many of them. And I think the presenter was really good at taking the participants sort of step by step through the risks of G6PD deficiency. It was also interesting to notice that they practiced upon each other, so they formed little groups during the workshops, and they could practice using the biosensor. And there was one participant who was G6PD deficient, yeah, that was an interesting change of roles in a way. And you know, he did have a lot of concerns that came from that, and sort of sought other information afterwards, and how, you know, regarding how he should address this.
That's interesting. Thank you.
Yeah, but it is interesting. It would be interesting to follow up to understand how to understand how, whether that lasts, because of course if you're in a one-day workshop, you're under the impression of what you just learned that morning, and so that's why I was wondering, you know, it would be interesting to follow up later if such a test gets introduced, or the diagnostic algorithm is changed, whether that risk perception changes again in the daily negotiation of different tasks that have to be performed, and also in the negotiations with patients about what are where they should put priorities. Sorry, Martin, you wanted to say something?
Yeah, Cristian, I have one query, not query, like I came to know one information regarding daily implementation in their work, like from the MT side, medical technology side. One of the MT from Khagrasuri, he stated like one implementing challenge when we like implement the device in the working environment, like it will go run out. Then what we will do to recover it? In this regard, they suggest they should train up to solve the problem, to make repair the device by self. So this thing are come up one of the interview from Khagrasuri.
Yeah, thanks for pointing that out. Yeah, I think this was, yeah, indeed somewhat consistent, that they were concerned about you know, things like repairs and distribution and continued access, and these concerns were also tied in with previous histories of technologies and diagnostic tools being implemented but then not really maintained. Yeah, thanks.
Okay, thank you very much for the discussion. Is there any other question?
Sonia, there's a question in the chat. about is there a difficulty in the participants to interpret the results?
Yes. Yes, right. Yeah, please.
I think not so much. I think just after the workshop, they had their sort of clear-cut indicators for what the results meant, and I think from the testing that was done just after the workshop, they responded pretty well with the interpretation of the results. I'm not sure if yeah, Shafiul has anything to add on that. I think from last week's presentation, I think what was interesting was the need to also include and involve, for example, doctors in this process, because the doctors are the ones who are actually asking for specific results. For specific tests to be done. And need to work with that interpretation of the results. But I think because it was quantified, that made it quite easy for them to interpret it. But I'm not sure if Shafiul has anything else to add, or Martin.
So hi. Yeah, as Cristian mentioned, so I guess there was no issue about the interpretation, so that was easy. But what we mentioned in the earlier presentation, that sometimes they overlook the G6PD value. So when they should stop, or hemoglobin value. So when they should go back to check with the other gold standard test. So the interpretation was not an issue, but maybe some small issues like to check the hemoglobin and others. So they were quite easy. Yeah, thank you.
Okay, thank you, Shafiul, for the clarification. Anybody else? Yes, Gonzalo, please.
Yeah, this is Martin. So I have one query. So I came to know one of the interview experts. He suggested as RDT is conducted by our CHCP, like community healthcare provider. So this device is like RDT. So they can be considered as a part of daily practice, like MT. So as I know, in the Biosensor machine there is only a buffer. So I have no idea, as a social science student, the buffer, if it is possible to store in a room temperature. Cristian or Nora?
If it indicates room temperature.
Yeah, because in every community clinic is a big made building, and it is it's situated in a quite good place. So I think if it is not mandatory to maintain like 4 degrees in the buffer, and if it is possible to maintain the buffer in the room temperature, then I think we can consider the CHCP like community healthcare provider. As you know, the medical technology also stated that most of the malaria cases are treated and diagnosis so far by the CHCP in the community level or healthcare provider level, not in the MT. So community healthcare provider only refer the severe cases to the proposal level. So in my perception, we could include the CSP in this list, like empty. How do you think, Cristian?
Yeah, thank you,
Yeah.
Martin. I think these kind of technical considerations around room temperature, storage space, supply, but also distance, travel, remoteness, etc., all have to come into consideration when talking about where it could be deployed and who could be conducting it. And I think there's a difficult balancing act to be found. And as Cristian mentioned, I think the data also shows that those balancing acts might not be able to be standardized in the same manner across the country, just because of the kind of constantly changing target that malaria represents. So that those things definitely have to be taken into account in a rather comprehensive analysis when talking about implementation.
Okay, thank you. So I saw two raised hands, one by Gonzalo. Maybe you can go first, and then Shafiul.
Thank you. The anecdote you said of someone in the training testing G6PD deficiency and some of the conclusions you drew made me think about the medical technologist is going to run the test but isn't going to communicate the test result to the patient, whereas the community health care work, if I'm understanding correctly, the workflows that you were explaining would have to do both. Was there any discussion around also that additional burden on the community health worker of not only just having to test the result, but run the test in addition to everything he or she does, but also that additional content and process of counseling and communicating the results to the patient?
Cristian, I don't know whether there was anything in that. I haven't seen anything in the data specifically on it, and that is because we didn't include the community health workers as participants in the study, right? The resources just didn't allow this, the frame of the study. But Cristian, maybe there was something in the discussions in between or in the field work?
No, I mean, there were a lot of discussions as to their sort of skill set that they have perhaps to use the test, but indeed it would have been quite good to see how the work environment of the community health workers looks like, and the communication and the kind of information that they have to transmit, and the kind of care that they have to provide to patients. But from the medical technologist point, they don't really have all that much interaction, I think, with community workers, because community workers often discuss at upazila level with doctors or with nurses more so than medical technologists. Yeah. So I think that would have been quite interesting to explore.
Okay, thanks, Cristian. So Shafiul, please, you can go next.
Yeah, so just to clarify some points about Cristian's presentation, some points came out in the discussion. So, the true that most of the cases are diagnosed at the community level. And, but they are not actually the government community workers. Like there are 20 NGOs in our national, is a partner of National Malaria Elimination Program, and they have health worker at the village level. So they actually go to door to door and do RD. So
sorry, is it my connection that's interrupted?
No, he broke. I
okay.
think he broke away. Yeah.
Yeah, Shaful, it seems like the connection was a bit bad, so I'm not sure that everyone could well hear your clarifications. Maybe you can try again.
Oh, sorry, I came back, so I was disconnected. So yeah, can you hear me now?
Yes.
Yes.
Seems to be better.
Yeah. Yeah. So what I was talking about, that the person of our malaria cases actually diagnosed by the community workers. So these are actually mostly these are mostly of the NGO workers and provide treatment actually received from the NMEP. So the patient actually don't need to come to the Upazila health complex. Only for those patients have some complications, and some areas, like in some places in Bandarban, where the places are remote and there is no health workers, like NGO health workers. So they have to come to the health complex. So then considering the device like
So, hello. Yeah, Shaful, I couldn't hear you well, and it looks like you're even not connected anymore. So it looks like we have lost Shaful, unfortunately. Yes, in summary, he clarified that the community health workers are handling most of the malaria cases, but as Nora said, it's a difficult balance to decide if the biosensor could be implemented at such a level, and definitely it would require additional research by including those community health workers in such type of social science study that we have done. So I think we are on time. We should wrap up. So it was a very nice presentation, nice discussion. I hope it was useful. Yes?
I talked to Shaful just now. He informed me he has an internet connection problem. So he will let us know later. So he informed me the one point, like we conducted this study with the MT due to the recommended by our donor maybe. So that's why we started this study with only MT, as I informed from Shafil just now.
Okay.
Hello?
Yes, Martin. your connection also doesn't seem very good. So I understood what Shafir said, that this was the study was done in close connection with the National Malaria Elimination Program, and so the idea was to start first with laboratory technologists
They
rather than
recommended to
community
start
level.
with the MT. That's why
Yes.
it was with MT.
Yes, definitely.
Yeah.
No, I mean definitely the lab technologists
my
have
point of view,
expertise.
Thanks. So
Yeah, exactly.
when I hear about this study in the middle of the part, then I argue. So then I said, so in this study, we should include the CCP, like in the community level, those who are working in the community level. In the on the other hand, they go door to door, and they deal like 95% cases in the community area. So, and they are also perform very, they have good reputation to perform RDT oil, because, and also they provide treatment in the community people from their community clinic. So we can definitely consider that group of people that I know from the case. So we can consider. Yeah. So
yeah, I think it's, as I think Nora summarized it quite well. There are so many aspects to be taken into account about the expertise of the staff, about the traveling of the patients, about the locations where malaria patients are, and it's definitely not a straightforward answer. That's why we need more research, and I think it was rightly pointed out that the conducting such a study by including also community health workers and also having more perspectives from higher level people, from decision makers, is also interesting. So in the interest, so thanks Martin for the clarifications, and that's really helpful. So I'm sorry, I think we are already a bit past time, so I guess it's better to wrap up. I'm sure these kind of discussions can continue on other levels, and so people can be free to get in touch directly with the group, with the team that has conducted this work. And as Emily also pointed out at the beginning, we have made the tools available on the box of the group, the questionnaires that have been used for this work, so feel free to look at them. And so thanks Nora and Cristian for the nice presentation. Thanks to the participants for interesting questions and discussions. And I think I hand over to Emily, maybe, to say goodbye.
Yeah, thank you so much from me as well to the presenters and participants. And I'll just add a note that the recording of this will be available and circulated within the members of this group mid next week. So yeah, feel free to again get in touch directly with the presenters or with us if you have any follow-up questions, and have a great rest of everyone's day.